Left ventricular assist devices, or LVADs, are used to maintain cardiac output in patients with severe heart failure, often those awaiting heart transplant. Right ventricular assist devices, as well as biventricular assist devices, exist but are less common and will not be the focus of this video.
There are many models of LVAD on the market today, made by manufacturers including Jarvik, Heartware, and Thoratec. Though the models appear slightly different, their basic function is similar. The LVAD functions by taking a mechanical implanted pump that transfers blood from the apex of the left ventricle to the proximal aorta. This pump is driven by an external controller unit and a battery, which the patient typically carries. The controller unit drives the pump using a drive wire that exits the abdominal wall through a surgical incision.
Any patient with an LVAD should have an implanted device, a drive wire that exits the skin, a controller, and a power source. These parts may have slightly different appearances depending on the manufacturer. The functionality of the LVAD can be assessed by auscultating the precordium. When the LVAD is functioning, there should be an audible, constant whir from the pump. The vast majority of LVADs on the market pump with continuous flow, so these patients sometimes do not have a palpable pulse despite having adequate perfusion. Perfusion should be assessed based on clinical findings such as mental status, capillary refill, and the temperature of the extremities. A mean arterial blood pressure can be obtained by either using standard technique with a manual or mechanical cuff, or Doppler ultrasound can be used with the manual cuff. Keep in mind, when using the Doppler, you will often not hear pulsatile flow, but a steady noise indicating non-pulsatile flow. However, even with a non-pulsatile LVAD, a pulse may be present because of the patient's intrinsic cardiac function. Cardiac monitoring should reveal clearly discernible QRS complexes. The EKG will likely show artifact from the pump and may be abnormal due to post-surgical changes, but a QRS should be clearly evident. Bedside ultrasonography can be used to assess right ventricular function. LVAD patients are reliant on an active right ventricle. The LVAD will be clearly visible on a chest X-ray. CT scanning is safe in LVAD patients, but MRI is contraindicated. Complications are common in LVAD patients. Upon presentation to the emergency department, patients should be assessed for these issues.
LVAD patients are typically anticoagulated with a goal INR of 2 to 3. This makes them at higher risk for bleeding complications, including gastrointestinal hemorrhage and intracranial hemorrhage. If these life-threatening causes of hemorrhage are suspected, treatment includes resuscitation, transfusion of blood products if necessary, and reversal of anticoagulation.
Complications can also be seen related to subtherapeutic anticoagulation. Consider thrombotic events including strokes and mesenteric ischemia. If these are thought to be the etiology of the problem, consider heparin, which is safe for use in LVAD patients.
Infection at the driveline site or within the device itself is also a common complication in LVAD patients. Treatment for this includes drawing blood cultures and starting early IV antibiotics.
Anemia is also common in these patients. If bleeding is not the source, consider hemolysis related to the pump. Blood transfusion is safe in LVAD patients.
ACLS protocols apply to LVAD patients, and defibrillation or cardioversion are necessary and indicated in unstable LVAD patients with ventricular fibrillation or ventricular tachycardia. The device is grounded, but avoid placing the pads directly over the drive wire. Keep in mind, LVAD patients, even though they may have dangerous rhythms on the monitor, may have enough output from the device itself to maintain adequate perfusion despite not having any native cardiac activity. If the patient is stable in a case such as this, talking to you and with a good blood pressure measured by Doppler ultrasound, you can consider pharmacologic therapy of the rhythm such as VFib or VTAC initially using a drug such as amiodarone. If this doesn't work and you need to defibrillate or cardiovert the patient, make sure that they are adequately sedated. Never do chest compressions for these patients, as chest compressions can dislodge the device, leading to cardiac rupture and uncontrollable internal hemorrhage. Whenever treating a patient with an LVAD, try to contact the VAD support person on call or the coordinator as soon as possible. this person's contact information should be carried in the bag that the patient has with them. The bag should also have some spare batteries and a spare controller if needed. Keep in mind, the patient and the family members have always had extensive training regarding the use and functioning of their LVAD. They should be considered expert consultants.
The treatment of an unstable patient begins by assessing whether the LVAD is functional. This is done by auscultating the precordium for the active whir of the pump. If the chest is silent, identify why the pump is not functioning. In conjunction with the patient and/or the family's help, change the controller or the power source. If the battery is depleted, an audible alarm will sound. Indicating need for battery replacement.
If the pump can be auscultated, immediately hook the patient up to the monitor and obtain a blood pressure, either by standard methods or by using Doppler ultrasound, as described earlier. If available, you also want to get a stat bedside echocardiogram. If the patient is hypotensive, your first choice of treatment should be fluids. Also, rule out anemia and GI hemorrhage immediately, as well as intracranial hemorrhage if the patient is altered. If after fluids the patient is still hypotensive, pressures are indicated. Dopamine is a good first choice.
Right ventricular decompensation can lead to instability in LVAD patients. Obtain an EKG to rule out a right ventricular MI. If a pulmonary embolus is suspected and no bleeding is seen, consider using heparin. Heparin can also be used for device thrombosis. If pulmonary hypertension is suspected and the right ventricle appears distended, correct hypoxia and acidosis.